Well, hello, my beautiful friend, and welcome back to another episode of Health Habits and Epic Living. Today, I am honored and excited to have a fellow colleague join me on the podcast, and it's Dr. Ben Malcolm. So, welcome, Dr. Ben. I'm going to introduce you. Dr. Ben Malcolm earned his bachelor's degree in pharmacology at the University of California in Santa Barbara, prior to his master's in public health and his doctorate of pharmacy at Toro University of California. Then he completed some postgraduate residency training in acute care medicine as well as psychiatric medicine. After his residencies, he specialized as a board-certified psychiatric pharmacist and began his career as an assistant clinical professor at Western University of Health Sciences. And when I was reading through your bio, I reached out and I was like, wow, we have a lot in common. We've both done acute care residencies and then went into specialization and then also worked at Western University as faculty. So I was excited to connect with you on that level. And now you work as the Spirit Pharmacist, which is how I encountered you because you are quite known in the space of psychedelics and helping people administer them safely, as well as harm reduction in the area. And that's really the reason I wanted to have you on the podcast and really talk through the risks, the benefits, and a lot of other things. So welcome, Ben. I'm excited to have you here.
It's an absolute pleasure to be here. Thanks so much for having me on.
And I don't find it surprising that our paths have crossed in the past and then our paths continue to cross. And I feel that they're going to cross in the future. But I want to get us started by, I think for me, I'll just speak from my experience as a pharmacist. I was taught that these drugs, psychedelics, are dangerous, they're harmful, they cause you to have psychotic breaks, bad things happen. And I'd love to get your take on just setting that tone around psychedelics, because I know they're having a bit of a renaissance now. I know a lot of podcasters are talking about them, which is how I developed an interest initially getting into this space, because I had learned through my pharmacy training that they were to be avoided at all costs and illegal, and which they still are for the most part in most states, but really that there is some therapeutic value behind these. And it wasn't until I listened to these podcasts that I started to open up my mind and saying, wow. So I'd love to hear your journey in this space and how you got into the psychedelic realm.
Yeah, so honestly, a lot of my educational pathway to study pharmacology in undergraduate and then go to a doctorate of pharmacy program was inspired because I just always had an intellectual curiosity about drugs or substances generally. And it really started with watching reality TV shows about addiction, like Intervention. And so there was something that just fascinated me with addictive substances, which many of them are regulated as illicit or Schedule I types of compounds. And it really inspired me to start even doing my own citizen research as far as just reading different anecdotes about drugs that were regulated as illicit compounds as a teenager. So I discovered an anecdote repository website for psychoactives around age 15 or 16, right? This is 2001, 2002, and it was arrowwood.org. The site's still out and available today. It's grown a lot since then. And so it was reading through, report after report about things like cocaine, about things like opioids or heroin, about things like methamphetamine, and seeing the, I'd say, relatively predictable types of trajectories that persons would be on when they started using those types of substances and got deep into them, that helped me learn a little bit more about what I think being addicted to drugs is actually like from the kind of user perspective, or sort of how this even occurs, then this sort of slippery slope that they are on. But then I also found other reports about particularly psilocybin containing mushrooms and MDMA, and the trajectory of the user and the anecdotes were just so much different overall that really by the age of 17 or so, I'd come to the conclusion that these substances just did not have the same addictive risk. A lot of persons were saying they had wonderful times and they weren't using them compulsively or an obsessive kind of addictive pattern afterwards. And even the persons that were saying things that I didn't have that great of a time with psilocybin mushrooms. In fact, it was psychologically very, very difficult. And there were some sort of hallucinogenic aspects that I might have even found scary. But you know what? I woke up the next morning And I just felt more comfortable in my own skin than I ever remembered feeling before. And it was like, there is something different about these types of agents that I think really led to some level of experiential curiosity around the time that I was starting undergraduate. And I'll skip the kind of cosmic travel log, right? But I had some wonderful experiences there and studied pharmacology. I was interested in some other things. I was playing the indigenous instrument, the didgeridoo. So I was interested in world music. I was interested in native types of music. And so it was kind of there that I came across the ritual use of peyote, right? And from the anthropologic literature that was available at some of the special collections in the UC Santa Barbara Library, I was just finding things like the doors of perception, right? I was finding these accounts of different anthropologists that had gone to, Native American peyote ceremonies or studied the Native American religion of peyotism. And it became apparent that if you take one of these psychedelics in a ritualized set and setting, there's a very good chance that you're going to have what they were calling in that literature a bona fide religious experience. Today, we would call that a mystical experience, with things like psilocybin mushrooms or other sorts of classic psychedelics, which are things like mescaline, LSD, and DMT found in ayahuasca. I really just had a different opinion about them that had come about through some of the projects that I'd done as a formal student at UC Santa Barbara, and then a lot of my just kind of background of research, right? So when I got to pharmacy school and we're kind of like, okay, yeah, we're going to have the substance abuse modules, and this is hallucinogens of abuse 1, and this is hallucinogens of abuse 2, as far as what the titles of those lectures were, right? It was already something that I was kind of like, well, I'm not going to rule out that they don't have some sort of adverse effect profile, or that, they may not be a great fit for absolutely everybody out there. But I already know that what you're presenting is really just one side of the story. And it's not even the side of the story that is probably the most likely outcome for the vast majority of persons that are approaching or have approached those types of psychedelics or substances. I didn't go to pharmacy school because I knew I wanted to be a retail-based pharmacist. In fact, I just really didn't know what kind of pharmacist I wanted to be. It just seemed like a logical extension of what I'd been learning in undergraduate, and I knew I had a passion for studying those types of subjects or topics. And I really just went in wanting to experience all that pharmacy had to offer. So, I studied hard. I was in these different sorts of leadership positions and things like that. You're in a doctorate of pharmacy program these days, clinical pharmacy, pursue residency, right? So I found myself into a general acute care residency program, and it was an incredible residency program. I really learned a lot, but it was apparent that I was kind of getting burnt out. It was apparent by about halfway through that year that probably just being a hospital-based pharmacy, even a clinical pharmacist within that general acute care setting probably just really wasn't the overall best fit for me. And it was that point in time that I would say legendary psychiatric and neurologic pharmacist, rest in peace, Kim Talion, gave me a flyer for a second year residency opportunity in psychiatric pharmacy. And something just kind of clicked at that point that, what? The thing that's most interesting to me now is the thing that inspired my interest in this educational pathway at the beginning of the day. And now this is 2015 or so, and the world has become interested in psychedelics at that point in time, right? And so I want to say that I was just in the right place at the right time, in that the clinical trials and some of the things that were happening with psilocybin and MDMA, esketamine, Spravato is actually being FDA approved by that point in time. Some of the others are getting breakthrough designations. These are not just hallucinogens of abuse. These are things with phase 1, phase 2, going into phase 3 efficacy trials, right? And demonstrating a reasonable safety and tolerability profile, right? And, the signals or hints that you're getting of efficacy are also quite strong from the existing data. It was kind of like, you can have a balanced conversation about these things, right? Because it's never illegal to deal information, and it's never illegal to counsel our patients about any type of drug, right? But we need to have evidence-based and objective sorts of conversations. And so if it is crack cocaine, yeah, you can counsel people about crack cocaine, but it's going to be very difficult to have a conversation about all the benefits of it, because that's just not supported. Whereas with things like MDMA, psilocybin, and a number of other psychedelics at this point in time, those conversations are possible to have. recommendations for use, suggesting they should go out and use it, a medical clearance for use, providing products for persons. These are lines that you probably don't really want to be crossing overall, unless maybe you're in a state-sanctioned program in a clinical trial, or that there are selected sets and settings and things like that where, you can do that, right? But what is Spirit Pharmacist, or what I do now? I'm a psychopharmacology consultant and a psychedelic educator. And I think in sort of like a colloquial or layman vernacular, I'm an internet drug information dealer that tries to bridge the gap between your psychiatrist and shaman, right? Or your psychiatrist and whoever the sort of psychedelic facilitator is, if you're considering one of these, I think, state level programs in Oregon or Colorado. I have my own experiences in all of it, right? There's a cosmic travel log that went along with all the pieces of paper, right, that kind of qualified me or put me in a position where I had that depth of knowledge to deal the information to people. And it really is both things that I draw upon to do what I do, I think, effectively for people. But that's, I think, the backstory, or just how I got a very different opinion about these agents from a very young age.
Fascinating, fascinating. And I know in the circles that I have been in where, psychedelics are used, your name does come up because we are part of people who want to advise people in the right, proper direction with the right medical clearance, with looking at if there's drug interactions, what shouldn't be taken, what are safe doses, all the things that you have been very instrumental in helping people navigate and use your experience as well as your in-depth research of using and looking at these products over time. I do want to say that we had met before this conversation, and there was something that you brought up that I found very interesting, and I'd love to kind of circle back to that conversation a little bit and revitalize it here for the audience. I think the way you described it helped me understand it a lot better. I think a lot of times when we think something is approved by the FDA, that it is, of course, safe and efficacious, right? That's what the phase 3 clinical trials go to prove. But that doesn't mean that there's no risk. And particularly around the SSRIs is where we started talking about, like, okay, right, we know that they're antidepressants or, these drugs, class of drugs, SSRIs. And I'm not just picking on SSRIs, but that was where our conversation was about, is that there are inherent risks to being on those medications. And when you compare those risks to potentially something like some of the psychedelics, not all of them, but some of the psychedelics, it actually looks like the psychedelics are less risky in some regard and even more therapeutic for certain patients, given the different conditions. Can you elaborate on just a little bit about SSRIs? And then it's not to say that they shouldn't be on the market or they shouldn't be approved. They do have utility, but I just don't think the common perception of them is they kind of get a hall pass because they are FDA approved.
Yeah. Well, even going back to like the first year of pharmacy school, right? They were kind of like, why do we have a regulator like the FDA that approves prescription drugs? Because they are dangerous, right? Like by definition, FDA approved drugs are dangerous drugs. They're more dangerous than, you need some level of FDA approval to even sell medications like over the counter. But if you're getting it via a prescription pad, right, that should be a surrogate marker that the medication actually carries like a significant level of risk, right? We also think that there could be a significant level of benefit to them, and that's why they are just available overall. But it's fair to say that any drug that is available through prescription and is FDA approved carries a level of risk to it. With the SSRI types of agents, I think that you could probably divide stuff into what we might think as lower risk types of things happening on a more common type of basis. Overall, I think we tend to call those things side effects. They're usually more manageable. They can oftentimes dissipate with time. Sometimes they can have unintended benefits, right? If a side effect is drowsiness and the person has insomnia, maybe we dose it at bedtime and that actually helps them, right? Rather than just being always a drawdown of the medication's use. But they also have more serious types of things, and we would call those more like adverse effects or adverse reactions, right? And sometimes we could do things that would make those things less likely or preventable overall, right? But from the idea of just like law of large numbers or laws of prescribing, they're not always straightforward or predictable, and they usually always carry, or they do just by definition, carry a level of harm to them. Sometimes it's reversible and sometimes it is irreversible. Right. And so I think since the advent of SSRIs, and Prozac or fluoxetine was the first one that came to the market, right, in the late 80s or so, we've really seen this expansive sort of genesis of them to the point that we've got, a number of different agents in the SSRI or SNRI, like a very related type of category overall. And we've seen the numbers of long-term users of those agents increase, along with an increase in the prevalence of the conditions that they're used to help, like depression, anxiety, PTSD, and OCD. So this strongly suggests to me that either the efficacy of these agents is pretty mediocre at baseline to the point that they're not necessarily even effectively managing things like depression, anxiety, PTSD for a lot of persons, or the world's just becoming a worse place and the numbers of those conditions is increasing for other types of reasons out there. But there's been a whole lot of information that I think has come out in the realm of psychiatry, maybe in the last 5 or 10 years. But I think that patients have been telling us about it for at least the last 10 or 20 years that, like, I can't stop these. These are really actually hard to titrate and get off of without having a serious level of mood decompensation that carries a risk, even of things of suicidality and suicidal ideation sometimes. Also, during the titration phases, these drugs are not immediate types of acting things. You should get some counseling when you start them. Take this on a daily basis. You might have to increase the dose or two, right? It's probably going to be at least a couple weeks, if not 4 to 8 weeks, until the efficacy is there. And within that time frame, oftentimes you get things like side effects, upset stomach, a headache, an increase in anxiety. Sometimes, particularly if you're predisposed to bipolar conditions, you can unmask mania, because depression is the most common presentation of a person with a bipolar condition at baseline. So what are you most likely to do? Treat it like depression. You could actually unmask or push a person towards manic episodes. And if that was severe, it could carry a really severe level of consequence or risk to it. And then they all carry black box warnings, particularly for younger persons, right, 25 or less, right, that they have about a 2% risk of emergent suicidality, particularly in those titration phases. And I personally don't think that risk is solely limited to younger types of persons. I just think that's where the data is the strongest. And so where they've actually, acted and put the boxed warning on them. I would say in the realm of side effects, like difficulty with intimacy, right, difficulty with orgasm, difficult achieving strong erections, or feeling a lot of pleasure is part of the SSRI side effect profile, but it seems for some small, right? This is a rare adverse effect. A person could stop those drugs and that functionality doesn't ever really recover. It seems like it's more of a tardive or irreversible type of side effect at that point. So, right, the SSRIs are overall, and frankly, if you look even through Medline and things like that, the trials that are published usually have favorable results, but for every trial that's published that has a favorable result, the drug company did a randomized control trial where it didn't beat placebo. Right? So there's a publication bias towards efficacy and safety that really may not be the objective truth of the agents. So I think that you got to use them for a relatively long period of time to find out if they work. That transition period where you find out that it works could be riddled with different types of side effects or even carry risks of adverse reactions. And then even if you get to a position where they've worked relatively well for you for a period of time, and maybe your depressive episode seems to have kind of dried up or concluded, or you're in a better place, you might find it difficult to stop at that point in time. The efficacy seems to poop out for a lot of people. They get 6 to 24 months worth of benefit, and then all of a sudden it's not working. What do we do? Are we going to increase the dose, change the agent? Those transition times carry risk to them, and sometimes a serious level of risk for persons, right? And so the idea of using a psychedelic where I could use it intermittently, right? Like, I don't want to say SSRIs are addictive. They're not regulated as controlled substances, but persons oftentimes end up dependent upon it that carries a lot of the same feelings. Like, I feel trapped with this, right? That are very much akin to habit forming and things that we really do consider to be more addictive agents overall. So the fact that I could use a psychedelic on an intermittent type of basis the fact that they tend to have rapid effects as far as the changes in symptoms. So a person gets immediate feedback usually, or within days or weeks, feedback on the efficacy of it overall. And when they do get a response, it seems to be robust, right? So if I was thinking, just from a hypothetical sort of perspective, what would be an ideal treatment for a condition? Well, something that wasn't habit forming, something I could use intermittently, something that gave me rapid results, and something where the results were robust, right? What would be a disadvantageous sort of treatment? Something that's mildly efficacious, that I have to take on a daily basis, that would hard to stop, and also carried serious risks of side effects or adverse reactions, right? And so you sort of paint it this way, and all of a sudden the psychedelic substances are looking like a great deal and almost like ideal overall as far as like what you would even be seeking in a treatment for persons. And so, yeah, the SSRIs, frankly, we do have what, 35 plus years of data. They're widely used overall. The psychedelic trials, it's emerging information. We're in the realm of phase 2, phase 3. Some of the numbers are pretty small. Some of the inclusion exclusion criteria are pretty tight or restrictive overall. So we probably will find that there are some more risks to consider or discover as the demographic populations or different types of illnesses and disease states do get tested, right? Or persons find out through these state level programs and things like that, right? So it really isn't apples and apples as far as like the totality of evidence, but so far the psychedelics are looking wonderful, right? Like almost every time they've done a phase 2 or phase 3 trial, it's like, this is an unprecedented result in psychiatry where a lot of people got better. It clearly beat placebo and the effect size was huge, large. Really
Yeah.
huge is not the correct term overall there, right? Whereas the SSRIs, it's like most of the time, half the time, it doesn't beat placebo. When it does beat placebo, it tends to be 20 to 30% better on average and the effect size is small.
Yeah. Yeah, thank you for highlighting all that because, when you put it into that context and you see like, here's a drug that, works maybe just as well as placebo or a little bit better, but the person has to be on it for the rest of their life and it's really hard to come off. And then it causes sexual dysfunction in a lot of people and other kinds of like, when you start like listening to all of that, when you were highlighting all that for me, I started to like reevaluate these medicines a little differently. And like you said, when you're looking at some of the research that has been done already in humans about depression, PTSD, anxiety, and how psychedelics have had this robust effect that lasts months. And some of the data is out to years later, and they're not needing to redose or redose just periodically to sustain the effect. It makes it like, wow. And you don't have all this long-term side effects, adverse effect profile. It really just starts to change my perspective a bit on like, oh, so interesting that just to evaluate that for yourself.
Maybe just to play devil's advocate for a moment, right? I
Yeah.
think with the SSRIs, a lot of the side effect profiles could be linked with the chronicity of use, right?
Mm.
But what
Hmm.
we are finding about the psychedelics, and there have been some safety reviews and things that have come out that do suggest that in persons that have neuropsychiatric conditions at baseline, a person can have a serious adverse event about 2 to 4% of the time, like overall, right? And just because the drug is used intermittently doesn't mean that some of those adverse reactions and adverse events couldn't necessarily present in a relatively chronic type of fashion afterwards, right? And so I do think that things like hallucinogen persisting perceptual disorder, right, is a possibility, right? Things like depersonalization or derealization, right, are things that can occur to persons. And it probably just boils down to what we're finding out about psychedelics from the neuroscientific type of angle are these are agents that cause a high degree of neuroplasticity, and that's a bit of a double-edged sword in some way. And what does that mean? It probably means that it makes their consciousness and their psychology, their biology, maybe even, right? There's a link between those two things, right? More moldable. So the ideas around safeguarding persons with psychedelics is strong screening, adequate levels of preparation and counseling ahead of time, trying to obtain as much informed consent as we can, using them in controlled or safe sets and settings, right, is a kind of colloquial vernacular around that sort of piece. And then integration plans afterwards that help a person put the lessons or what they sort of felt in their experience into practice overall. And again, like I remember being in middle school and there'd be all these rumors floating around about LSD or something, right? And it would be like, well, you better not use LSD because it could change you. And then Michael Pollan wrote a book called How to Change Your Mind, featuring psychedelics, and then everyone wanted to use them, right? And so change itself and the ability for your brain to change is a double-edged sword in that if you're taking high doses in uncontrolled environments without preparation, without adequate informed consent, and frankly, with perhaps less skilled persons at the facilitation practice, or frankly, some persons that may just not have very good intentions overall, it's really possible to take your moldable piece of putty and smash it into a shape that might set in something that you really didn't want overall. And it's also possible to take that piece of putty and make a beautiful vase in a different sort of set and setting with some skilled sorts of hands and boundaries around it, right? So even though the psychedelics are truly used in an intermittent fashion, the vast majority of the time, even when a person has a difficult or scary or challenging, has it sort of been rebranded, like the bad trip has been sort of rebranded towards challenging or difficult experience. Bad is not the same as difficult. Bad is not the same as challenging, right? But some persons can have bad outcomes sometimes. And so I think that we have to be careful. I think that historically, the hallucinogens of abuse that demonize and sensationalize these types of things and make out that those are really common sorts of problems, well, that's false. But the idea that they have no ability for long-term problems that could come along with use and maybe with certain predispositions or certain unsafe sorts of settings, like, okay, the truth is like somewhere in the middle, and that overall the risk-benefit profile seems great, but they're in the process of FDA approval because FDA-approved drugs have danger to them, right? Kind of going back to where we started.
Yeah. And I like how you set that up. It is so important. And it's something that I've had other guests on the podcast talk about as well, that the set and setting, having a provider that knows the medication so that you can, if it is a challenging, not all of them are, but if there is a challenging experience that comes up, you know how to integrate that. You can land back into reality and be supported. That's the integration process. So important to take these in a therapeutic way rather than a recreational way. Not that, telling people what to do, but if you do it in a therapeutic designed model, you have more chance for this to go in your favor. And like you were saying, these are agents that rapidly change the brain or have the potential to. And sometimes that's why they're so attractive, right? We find it very hard to get the change we want. I've seen patients who this has radically changed their depression and they're no longer depressed, or it's radically changed their addiction and they no longer want alcohol or the cigarettes. And just seeing that transformation, wow, that is very powerful when they do work and life altering for the client or the patient.
Yeah. I get somebody like, how do these things work?
Yeah.
It's like, well, we're still discovering it. I think for some persons, it truly can be neurochemical, right? Like there really might not be a whole lot that they need to do afterwards. For some persons, it seems metaphysical and spiritual, like it opens them to something larger or greater than themselves. It connects them back. They don't feel like they're an alienated piece of the universe that doesn't belong, right? They feel connected all of a sudden. Could be connection with self, right? Rather than something that's more cosmological. I think with many models of trauma or PTSD, it's not necessarily the things that happen to us. It's the loss of connection with our true self that results from those types of things.
Yeah.
I think that a lot of the times when persons do feel disconnected, they're in a lot of pain overall, they're often trying to medicate or sort of find ways to cope with that pain. And so they may have collected some maladaptive coping skills sort of along the way overall, like you're mentioning some of the substance use habits and things like that. And so a lot of the times when a person's kind of talking with us, it's like, well, will I have to do things afterwards? And it's like, quite possibly. right? There's essentially two ways to get a hot air balloon off the ground. You can pump hot air in it, or you can cut the lead weights that are holding it to the ground. And probably, if you really want things to rise, you should be considering doing some of both overall. And so there are some persons that, like, it's almost like a neurochemical switch and they just feel so much better, right? I mean, there's probably upregulation of neurotrophic factors and the energetic release, the sort of psychological experiences that are just occurring acutely that are driving some of that. And then for many persons, maybe even the majority of persons that are approaching that, the psychedelics are opening the door and saying, walk this way, but they're going to have to walk that way, right? It's not going to walk the path for them. And so some level of integration coaching, therapy, I don't know, maybe it is personal training, maybe it is dietary or nutrition wise, maybe it is writing letters to estranged persons asking for forgiveness or forgiving them, right? Maybe it's forgiving ourselves, right? There's a lot of different ways that persons can do it. And yeah, I think that from a medical angle or perspective, psychedelic assisted therapy is an incredibly important piece of this overall. And frankly, I couldn't do what I do if they weren't being studied within that medical paradigm. Like that, particularly the safety data, but the efficacy data that's following along now is what is going to set us free. I mean, and that is what's going to make these things available. But then also to just take that piece and be like, well, you need a refractory psychiatric condition to benefit from that. Well, frankly, I believe that that's kind of bogus overall too, because they have been spiritual sacraments for millennia, probably since really the dawn of recorded history, and maybe even before the dawn of recorded, before we record things with writing, right? There was oral tradition, right? And they were probably a piece of that. Some persons have even theories that they may have helped evolve areas of the prefrontal cortex that allowed the transition from primate to human being, right? Things like that overall. And so I'm very much of, like, I'm a cognitive libertarian at heart, right? And I love the sort of therapeutic paradigm. I think that's an incredibly important angle, particularly for persons that have more severe conditions baseline, right? The idea that they can access it through safe sets and settings with a lot of medical protocol and support around it makes a whole lot of sense. But it also makes sense that we're not going to be free while nature is illegal. It doesn't make sense that spiritual sacraments that have been around for thousands and thousands of years are hallucinogens of abuse with no accepted safe medical purpose or an inability to be used safely by a person in the general population with a level of screening and safeguarding, a safe sort of ingestion place or ingestion center. So I really like the retreat center model. I really like the idea that persons could access, spiritual sacraments that might be part of their tradition or might be something that they want purely from even an experiential type of angle. And even, right, like recreationalists, I need so many persons that really do use psychedelics in home sorts of settings, even sometimes. And maybe there is some level of ability, well, I hope I have a good time, right? But I'm really also trying to learn something about myself, and I'm not trying to do something reckless. And so there's therapy, and then there's things that are therapeutic, right? And so, okay, going to a therapist is therapy. Cold plunges, saunas, jacuzzis, relaxing music, sound baths. These are therapeutic, but they're not therapy per se, right? And so sometimes the language that we have around recreation equals abuse is like part of prohibition that is just like, if it's a drug that I'm recreating with, I'm a bad person. If the city sends out a recreational guide with summer activities, better sign up quick because it's going to fill up, right? And so recreation is actually a really important part of being an adult that is, we get too little of it as far as our like fast-paced hustler sort of culture that's out there. Work, 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 work. How many people are depressed or how many people are just burnt out, right? And burnout, there's a whole body of literature out. It's not necessarily a defined condition within the DSM, quite yet, but there's a whole lot of interplay yet. So it might just be possible that some adults need more time and space for themselves and actually need to play or recreate more. And, right, drugs have risk, right? Like it might not be quite the same as, going to the park on a nice day or do whatever is in that city recreational guide. But you know what? Yeah, even that. The swimming pool has risks, right? You could catch a condition, you could drown, right? And so life has risks in general, and it's just about taking risks in controlled and safe ways where we're well informed rather than in reckless and impulsive kind of ways overall. Because nobody won anything or got to anywhere that they really wanted to go without taking some level of risk to get there. Yeah.
Yes, yes, yes. There is risk. There's risk to getting in a car. There's risk to getting in a plane, right? Yeah, as you point out, the risk of swimming pools. But I do like your reframe on the recreation part of it. And I know for me, having a retreat experience versus a one-on-one container, way different. And I also think that there's something therapeutic when I'm there with a one-on-one model, because just having that empathetic witness, I think AA talks about that too, is having a support system or an empathetic witness to help you move through the grief, the mourning, the pain. It's like, in my experience, it's like my body was talking. It wasn't my brain. It was just all of this heaviness was just coming out of my body, and it felt so good. And it just felt so good to cry and then to just be with somebody who is holding that space and being with me in that, and having that empathetic witness felt like therapy, but definitely more therapeutic. It was just
Absolutely. Absolutely. It's really hard to heal in a closet by yourself.
Yeah.
A lot of people try, but
Yes.
and sometimes you can make some level of limited progress, but it's really difficult to get all the way there. And what you're saying is so incredibly important. Like a lot of the time, persons are, why should I have a guide for this? And some of it, right, it might really be some level of safety in all of it. But a lot of the time, if you're going to have that big of an experience, you just want somebody else to witness it, right?
Yeah.
Having a witness for what could be a peak experience and some of the deepest emotions and the release of some of those deepest emotional pains that you've been carrying for a long period of time. You want somebody there, supporting is one aspect of it, maybe, but just witnessing. It
Yeah.
really is an incredibly important piece of a healing process for a lot of people overall. Therapeutic process, right? There's different sorts of lingos and all that. They'll probably mean slightly different kinds of things, but
Yeah. Yeah. Just so healing. So healing. I definitely would consider that such a peak experience, even though it was difficult. It was just like, wow, I didn't realize my body was holding on to all this tension. I think that's like part of burnout too. You think you have to do it yourself and keep going and keep hustling, like you said. And like, I don't know, your body just stores that tension, even if you may or may not be aware that your body is storing
yeah.
that tension. But yeah, just to
Yeah,
let,
exactly. Like Bessel van der Kolk has this
yeah,
really, really important seminal work on trauma, and
yes.
the title of his most famous work is The Body Keeps Score. And I think if I had to write sort of a sequel to that with psychedelics, I was like, well, if the body keeps score, a psychedelic experience, particularly a therapeutic one, helps the body speak more. And so it's interesting that I think, again, like sort of like our taxonomy in all this, where did it start? Psychotomimetic. Mimics a state of psychosis to an observer. Nothing to do with the person's actually experiencing. Then what do we get? Hallucinogen. Okay, to generate hallucinations. No emotional content, no therapeutic value at all, just hallucinating, right? So, okay, so it mimics psychosis and then it causes aspects of psychosis. This is where the taxonomy of these things began in the West. Okay, psychedelic, mind manifesting or soul manifesting would be the translations there, right? To more specific sorts of words, entheogen, a lot of the times for the classic psychedelics like psilocybin or LSD, meaning to cultivate divine or to cultivate God within. Entactogen or empathogen with more your phenethylamine types like MDMA, right? Meaning to generate empathy or to touch within, right? Are those types and they really do get to describing some of the subjective activities. To psychoplastogen, neuroplastogen, the sorts of more terms that we have in neuroscience these days. So the first terms that are ever describing psychedelics for more of a biological type of activity rather than what we're thinking is going on from a subjective type of perspective overall. But the term, I mean, psychosomatic is perhaps like a bit like pejorative in some sense because like we're a mind body sort of organism. But I think that's it with like psychedelic, where it's like mind manifesting. So it's mind body manifesting, right? It's holistic, like it's holotropic in that sense, right? In that it's connecting the mind back to the body and allowing the body to do what it needs to do to precisely like release these stored sorts of tensions and energies that are, I think, a big part of what we know about essentially trauma. And I would add chronic stress to that too, right? There's sort of like really hallmark horrible events like trauma, and then there's chronic stress. And most persons have some level of both of it going on. Yeah.
Yeah.
Different.
Yeah.
So the language that we use to describe these things has undergone what I think is a really lovely evolution. And I still feel like there's more room in that for describing some of these somatic properties.
Yes. Very somatic for me. I know we're getting up on our time here, but I want to sneak in one more question because I know we're both pharmacists and we tend to geek out on, mechanism of action. But I really want to dive into like, what are some of the contraindications you see to psychedelic use?
Yeah, so I think some of the big ones out there are schizophrenia, or I would say like persistent psychotic episodic kinds of conditions, like schizoaffective conditions. The bipolar conditions, I think, really have almost blanketly been considered a contraindication for a while, but I really sort of focus, I think, a lot of the times on a bipolar 1 condition where the mania is severe, they go to the hospital, they've lost insight, right? Rather than a person that is a bipolar 2 type of condition where it is almost primarily depression. There's blips of hypomania that have occurred once or twice. They've never lost insight. It lasts for 72 hours or less. The consequences haven't seemed severe in the past. Maybe they've been exposed to a couple antidepressants and a stimulant at the same time, right? Where it's like, okay, those cocktails of medications could easily push a person that was predisposed to a bipolar 1 condition into severe mania. It never has for them. Right. Like, so the bipolar conditions, I think, really exist in a spectrum, and we're getting more nuanced as far as evaluating those types of risks overall. Maybe advanced cardiovascular conditions could be another one, right? Sort of thinking of persons that have had serious heart attacks, serious strokes, arrhythmias, things like that. Maybe not a well-controlled atrial fibrillation where they had an ablation and it never occurred and we've de-escalated the anticoagulants and things like that. But yeah, ventricular arrhythmias. I have had a pacemaker put in because I need a defibrillator implanted. Things like that just become, I think, a little too far beyond where we've gotten around to study and actually have the clinical safety data for. There's probably many other advanced neurologic sorts of illnesses, progressive illnesses, where there's a line, right? Seizure conditions, not well-controlled seizure conditions, where the seizures are grand mal types of seizures, right? Really could be thought of in the realm of contraindication. I think, like I mentioned, like progressive neurologic conditions, there's actually, I think, a lot of hope that psychedelics really will be helpful for, I think, earlier stages of a lot of those progressive neurologic conditions, maybe Parkinson's, maybe Alzheimer's, right? Maybe even earlier stages of things like multiple sclerosis. But usually with, I think, particularly the cognitive sorts of declines that persons can have, end stage Alzheimer's, major cognitive impairment, oftentimes does get to a place where the person is really cognitive impaired and maybe even having hallucinations and things like that. And part of that could be the condition. Part of that could be the dopaminergic meds sort of pushing them in some way, right? I think that when you get to persons that would have a whole lot of difficulty even understanding what the treatment is or what it could be capable of doing, right? Like it's just not in the realm of possible to gain the kind of informed consent that we probably need given where the data is at and the prohibition status of the agents. And so I think those are some of the bigger ones that come to the top of my mind when I'm thinking through contraindications. If we're talking about different types of psychedelic substances, I think in this conversation, it's been a little bit more psilocybin and MDMA. I haven't necessarily explicitly said those agents, but a lot of the conversation I've been focusing on really has been those clinical front runner types that have that phase 2, phase 3 data behind it. But if we're thinking about monoamine oxidase inhibitor containing psychedelics like ayahuasca, oh yeah, SSRIs become contraindicated, stimulants become contraindicated. Anything that blocks reuptake pumps of serotonin, norepinephrine, and dopamine or are capable of releasing those agents, Sudafed, dextromethorphan, right, stuff from your over-the-counter cough and cold aisle, could carry a whole lot of serious risk for those types of agents. Ibogaine, getting some headlines these days for its rapid ability to detoxify persons from opioids, maybe even treat other types of serious addictions like cocaine addiction. However, it is a pro-arrhythmic agent that causes prolonged QTC intervals, and there have been several persons that have died from fatal ventricular arrhythmias, or torsades de pointes is the one that probably does actually kill persons, to the point that those ibogaine guidelines, or what the guidance out there, it's sort of like, well, we need to be doing EKGs, we need to test liver function, we need to be measuring electrolytes, and if you're going to do it, you probably should be under telemetry monitoring at the same time, right? And so there's different types of psychedelics out there that do have serious drug interaction risks to them, that have more medical risk than I think classic psychedelics like psilocybin or LSD really do. And so a lot of the conversation around contraindications could be agent specific as well.
Yeah. Wow. Ben, there's so much here. I mean, I just want to piggyback on with some comments. Like, I've even seen these, not contraindication wise, but, for their utility when end of life and people using smaller doses or microdoses. And that might be different versus macro doses or these higher doses. And like you're saying, it's agent specific. So just knowing the pharmacology of each of the agents, right? It becomes really this nuanced conversation for the individual patient. And so I love that you are here as a resource. I know you gave, I think, a webinar last week I couldn't attend, and how even the GLP-1 agonists might be modifying some of the experiences and agents. So much value that you bring to this area, Ben. And I just want to thank you for all your work. I want to thank you for coming on the podcast today. And if there's like a physician or a practitioner or a coach in this space, or even, patients or clients interested in learning more about psychedelics, can you tell us how to find you or how to work with you? I know you do one-on-one consultation and all that.
Yeah, so spiritpharmacist.com is my website. That's the best place to learn about the services, the offerings, the resources that I have. I do offer just individualized level of consultation on an a la carte type of basis. I have a number of what I would say are sort of like layered educational resources, all the way from free downloads, blogs that you can access without paying anything. The webinars, like you mentioned, I do on a roughly monthly, bi-monthly kind of basis. There's a charge for those, but it's not so much overall, all the way to, sequenced courses that are, 10 to 20 hours of pre-recorded material, which really try to take you from a level of neuropharmacology to pharmacology of specific sorts of agents, all the way to the sort of clinical application, screening, drug interaction risks. And I've even started a psychedelic screener mastermind program for professionals that are just wanting to go a whole lot deeper into all of these types of substances, their drug interaction risks, and really up their level of confidence and competency when it comes to the biomedical risk assessment piece that I think is going to be absolutely crucial to this psychedelic renaissance rolling out well and safeguarding the maximum number of persons, and ultimately letting them do things that make sense for their conditions that lead to the best possible outcomes. And you know what? That's just what pharmacy is about, right? It's about safety, it's about efficacy, it's about education, it's about empowering individuals. And so there's a number of things that I have, really depending on who you are, what you're looking for, what your budget is, and you can find it all at spiritpharmacist.com.
Fantastic. Thank you so much for being here today, Ben, and for all the education that you provided us.
It's been so wonderful chatting with you. Thank you so much for having me on the show.
Thanks for listening to the Health Habits and Epic Living podcast. If you're ready to take the next step to improve your health, wellness, and lifestyle goals, head over to www.epicyou.com and sign up for my weekly newsletter. Again, that's EPICYOU.com. Please note that the information in this podcast is for educational purposes only and does not constitute medical advice.